Hi everyone, I'm Dr. Nazanin Alavi. I'm a staff psychiatrist and assistant professor at Queen's University in Kingston in Ontario, Canada. And I'm going to talk about digital health and how using online psychotherapy could help mental health during COVID-19. Going to share my screen right now. Use my slides. Just a second here. Okay, so this is, as you can see, digital mental health at a time of pandemic and scaling up service capacity. In terms of disclosure, I am a co-founder at Opt Inc. And we have developed an online psychotherapy platform that I'll actually talk a little bit more about that during this presentation. I would like to talk a little bit about mental health. I'm sure you're all familiar with these numbers more or less, but about 1 in 5 adults suffer from mental health disorder in a given year. And unfortunately, less than half receive the care they need. And this causes the government a lot of money, which is for United States is 500 billion per year. So depression is a common health condition which affects 350 million people around the world and is one of the common mental health disorders. Talking about psychotherapy and specifically cognitive behavioral therapy, it is one of the most widely investigated forms of psychotherapy, and it is effective in reducing symptoms of anxiety and depression, which are one of the two mostly diagnosed mental health disorders. So before COVID-19, I wanted to tell you a little bit about how I was looking into developing my online psychotherapy clinic. So many years ago, like more than 12 years ago, actually, I was doing my postdoc fellowship at that time and working with mood and anxiety disorder problem. I realized many people were suffering from depression and anxiety, and they wanted to get help and they were looking for psychotherapy, but they preferred to see a therapist who would understand their background and culture, and they preferred to speak in their native language, although, for example, their English was very good and they had a job like in North America. But when it comes to problems like with mental health, emotions, is easier to talk with like in your first language. So I was thinking, like, what if you're in a city that there is no therapist that can speak the same language, or like they're not available, you can do like online psychotherapy and see a therapist in another city. That's how I thought about developing an online psychotherapy clinic. And further to that, there are lots of other barriers to receiving psychotherapy. One of them is obviously distance. So like remote areas, like people are not able to come to their sessions because like they can't. The transport is a problem. As I said, the cultural background for immigrants and refugees, the financial limitation. So it is more expensive. And as I can discuss later, it would be the financial cost for patients would be less, because the time that the psychotherapist will spend with the patient in online is less, because the psychotherapy modules can be pre-designed, and the time that the therapist spends with them could be 1/3 or 1/4 than in person. So the cost will be less. One of the other things is stigma. People have to take time off from work weekly because psychotherapy is usually every week. And then people might ask them, where are you going? And they would know. And unfortunately, there's still stigma. And the wait time. if like the therapist spends 1/3 or 1/4 of the time with the patient, the wait time will decrease significantly. So at that time, like it was like, okay, like 2.5 billion people are using internet, so we can look into like developing online psychotherapy clinic. Then COVID-19 happened. To just look at that briefly, it was like December 2019 that WHO was notified that there were several cases of pneumonia in China, and that the virus was responsible for this did not match the other viruses. And then in January 2020, China confirmed that this was coronavirus family and then COVID-19. So this has significantly changed everyone's life, because, and like, then it has caused anxiety and depression. Some people had anxiety, depression, and like it made it worse. And some people never experienced it before in their life, and then they are having some symptoms. And why is that? Is because many countries, like most countries, they are trying to get people out of streets, out of parks, right? Because they want to decrease the spread. And this is what we call like self-distancing. But it is becoming more extreme because people have to stay at home, and it's kind of like the lockdown, and like everything is becoming virtual. So the anxiety first is a normal reaction, because what is big in this is like sense of uncertainty. So if people knew that, okay, this is 2 weeks, it will end, this is 1 year, it will end, the level of anxiety would be less. But is the sense of uncertainty that is causing it, causing even more stress and anxiety. And then this stress that what will happen to me, and even to the loved ones, like people have kids, like their parents, people close to them, and this is causing big levels of stress to people. It's causing symptoms of anxiety and depression. And also there is a lot of concerns around school and work and finances, because people have lost their jobs and they're worried about like the finances and many other things. Kids are not able to go to school anymore, and people have to homeschool. So all these symptoms of anxiety and depression is worsening. So I wanted to share some data that has been out. So the Kaiser Foundation has done like a survey, and people have said that like 21% have said that the pandemic has caused major negative impact on them, and 27% said that there has been minor negative impact. In the recession that happened in 2008, it was shown that 1% increase in unemployment increased the suicide by 1.6%, which is very important to keep that in mind, because it shows us when we calculate that if the unemployment increases by 20%, it can cause about 18,000 suicides and 22,000 overdoses. If we look at the amount of alcohol that is sold, it has increased by 55%, and 75% of that is hard liquor. And this is like the short-term effect, but there are actually long-term scars. The hospitalization because of overdose 4 years after the Katrina was 35%. So just like forgetting about the short-term effect, the long-term effect would be big as well. So how could online psychotherapy help, and specifically cognitive behavioral therapy, and what it is? The reason, one of the things that I started to do, as I mentioned years ago before COVID-19, is cognitive behavioral therapy is very structured. So it works very well in terms of like doing it virtual. So it has a part, as you can see, cognitive. So it's the cognition, how we think, and the behavioral. So when something stressful happens, like COVID-19, or even like smaller stresses in life, we will experience lots of thoughts, and some of them being negative, that will cause us having different emotions and experiencing different emotions. We could feel sad, stressed out, anxious, angry. Our body will react. Our heart might go fast. We might get short of breath, sweat, shake, and we will have a behavior. And that is like when you don't want to get out of the bed, like you don't want to leave the house, don't want to talk to friends. And these are all related. And if we make a small change to one part, we can make positive changes to the other parts. And this is about learning techniques and strategies to change the way we think. And it's not about being all positive or optimistic. It's about being realistic. So in a negative situation, when we are experiencing depression and anxiety, we see the situation even more negative. So CBT is about changing the way we think and also our behavior. I wanted to talk about some of the studies that has been done. So this study was done in 2011. It was on 77 individuals that have had the diagnosis of depression, also different kinds of anxiety, such as generalized anxiety, panic disorder, social anxiety disorder. And the treatment was online CBT compared with control group, and the results showed that the online CBT was helpful for treatment of both depression and anxiety. This one was done in Germany in 2009 in about 400 people, and online CBT was used as an adjunct to treatment as usual. And it showed that online CBT was effective in improving symptoms of depression, not only as an adjunct, also when it was used alone by itself. This one is a meta-analysis looking at 14 different studies. What's interesting, it showed that in short term, online CBT had a medium effect in decreasing symptoms of depression, but in long term, when they followed up in 3 to 6 months, it had a large sustained effect. What I thought to talk about is role of clinician support in eCBT. So there are different kinds of clinician support in studies that have been done in online CBT. If you look here, the first one that it says 0, it means that there was no therapist contact. In 1, there was contact by a therapist just before the study. And in 2, there was contact by a therapist during the study. And in the last one, the contact with the therapist was before and during. And as the support by the clinician was more, the efficacy was higher. So if I want to summarize these studies, we can say that eCBT, the online CBT, actually can address the barriers to mental health access that we discussed, the barriers. And compared to the traditional psychotherapy, which is in person, face to face, it seems that eCBT is shorter, so it is more time and cost effective, because what the therapist can offer to one person, if it's face to face, they can offer that to 3 to 4 people in the same amount of time. And the meta-analysis didn't show that eCBT was inferior to face-to-face CBT. And while all studies show that online CBT was helpful, adding some guided support increased the efficacy. So if like they were writing the patient's feedback, if they checked with them every week, the efficacy was higher. As I said, I started this developing modules and for CBT for depression and anxiety 12 years ago. First, we started sending the modules to the patients by email and sending them feedback by email. But then a couple of years ago, we realized it's not as secure as we wanted it to be. So we developed an online platform, which is called OPT, Online Psychotherapy Tool. This is the website to the platform, and all the patients and the therapists have access to that. They have their username, password, so they have to log in. And if I want to give you an overview, so each module, based on what it is, it has specific number of sessions. For example, for CBT, for depression or generalized anxiety disorder, is 12 sessions. It's about like 30 slides kind of thing. The patient should go through them themselves, and each week they will receive a session, and the material is similar more or less to in-person sessions. As you know, each therapist do it differently, but this is pre-designed based on evidence, and it highlights a different topic each week, and it has general information, in overview of skills, and similar to all other CBT that programs, it is homework based. The person does the homework and submits to the therapist, and the week after they will get personalized feedback and the next session. One of the questions that many people ask is that what do you do with, like, safety concerns? So similar to many other things, we'll in the beginning say this is just for you to learn skills, is a program for you to learn strategies, is not for crisis. I always explain to people that if, like, after hours, you have GI bleeding, you can't just call your family doctor and leave a message. You have to go to the emergency department, get the help you need. So we don't check this during the week, and it's not designed for crisis. We have never had a problem with that. Just an overview of sessions. For example, for depression, we start with first session was depression, and share your story, and they tell us what they're hoping for. Then 5-part model. As we go, thought record, action plan. The last session is review, and this is just wanted you to see how a session looks like. It just goes very fast, but the patients, like, it takes them like about 40-50 minutes to go through this session. So basically, they will see the material. At the end is their homework, and they will submit that, and it will go to the therapist. So this is the session they will receive, and then they will submit their homework, and then they will receive the feedback. And I put a sample, like, for all feedbacks that we write, we have a template, and based off the patient's homework, we will change it. So we start with, okay, thank you for sharing this. We summarize the previous session, and then we say, like, what they did right or wrong, and we will give them a feedback. In terms of my research, I have done different studies. The first one was on depression. We had the inclusion criteria of people 20 to 40, and if they had active suicidal ideation, or they were receiving either medication or psychotherapy, they were excluded. And 144 people showed interest. We did the Beck questionnaire, and we had 93 that did the study, and 47 received CBT, and 46 were in control group. At the end of like the study, we also, like, they did 10 weeks and also 6 months follow-up. And if you look at the result, people who received the online CBT, their scores significantly improved after 6 months. The result was still good, and in the control group, there was no improvement. We did the similar study for generalized anxiety disorder, and we had 62 total patients, and there was 31 in each group. And again, there was improvement in online CBT group but not in the control group. We did a study for adolescent, and the result was very interesting because in this group we had we compared the online group with in person, and there was significant improvement in the online group, as you can see here. But and the online group showed decrease in anger, anxiety, depression, and behavioral disturbances, but the results were significantly stronger than the live group. And we think the reason is that the adolescents were interested more in online CBT. They didn't want to take part in in-person groups. So the current research that we are doing at Queen's University, one is on anxiety, offering online CBT for anxiety. We have 3 groups, 3 arms, 1 online CBT, then medication, then online CBT plus medication. I have just put the chart for medication because there is a specific algorithm for that. And we haven't completed yet, but one thing that is interesting, in our online group, the total number of sessions is 12, but the average of sessions that people who quit in the middle is like during the therapy, the average sessions that they complete is 10. But in person, when they quit, the average sessions that they complete is about 3 sessions. So if they do online, they usually complete more sessions. And the ones that so far have completed the therapy, the quality of life has significantly improved, and their questionnaire of GAD-7 and DAS has significantly, the scores have decreased. Then we have a study on online CBT for depression. We are comparing online CBT with treatment plus the treatment as usual, and group CBT with treatment as usual. Again, in our online CBT group, the number of sessions that they completed if they quit was 9. Quality of life has significantly improved, and PHQ-9 and quits has significantly decreased. During COVID, the study that we have just started is online delivery of psychotherapy tailored to patients suffering from mental health problems, specifically depression and anxiety due to COVID-19 pandemic. So I just wanted to show you 2 sessions of the modules. For that, we have developed 9 sessions with focusing some, it's online CBT and focusing sessions on like problem solving and also resilience. So this is our session 1. So we have a focus on COVID-19, and like the examples are specifically for that. As you can see, that like we're saying how it is related. For example, the example is how like people think. If like they were coughing before, they were thinking more it is because of an allergy, but now it could be to COVID-19. We're asking them to set their goals and what they are hoping for, and is what I was explaining. This is session 2. We in the beginning is always checking how they are feeling, if they are working towards their goal. We explain the CBT, the cognitive part, and also we go towards the behavioral part as well, teaching the breathing techniques and encouraging them to practice that and which one is working better for them. So the future research that we're hoping to do is to develop an online clinic for patients suffering with different mental health problems, not only with mood and disorder, like for depression and generalized anxiety. So what the modules that are almost done, it's for OCD, and then pain disorder, CBTI for insomnia, for social anxiety, PTSD, addiction. We have seeking safety, and also relapse prevention, and also we have DBT. And also this is a book that we have written. It's the first handbook for online cognitive behavioral therapy. And if you had any questions, feel free to email us. Thank you.